So I would like to invite everyone to our 9th APS COVID webinar. I think pretty much everyone is now well familiar with this webinars. So I'll just like to mention that we have the next event is actually happening at the APS March meeting, which will be, as you know, probably most of you, March 15 to 19. There will be 2 events specifically, and probably some more, but some dedicated sessions. Physics of COVID, organized by jointly by the Topical Group on Medical Physics and Forum on Industrial and Applied Physics. And then another invited symposium between the biophysics and Forum on Education on physics responding to COVID-19 and beyond. And then after that, it's a little bit unclear. And part of the reason is that we don't know whether it's still worth continuing. And obviously it's worth like continuing webinars. They were thinking that maybe turning them into more into roundtables, that we can just chat a little bit more. We see that, you know, the discussions that we typically have are very interesting parts, and a lot of desire, a lot of discussion that happens. So we'll be sending out a survey to see how you feel like, and then we'll see how we move from there. With that, I would like to stop sharing. So I'm Robert Uri, a professor of medical physics, University of Wisconsin, and with my colleague, Professor Juan Bonot from Rutgers, we are welcoming today, I think the first ever married couple at our webinar series. And this is Daniela and Franz. So they've got an interesting path that we're chatting. So Franz comes from basically fundamental physics, studied and did his PhD in Munich, and then wandered a little bit around the world, including being in the US and France. But then I guess subconsciously knew that should go back to Munich, because there was Daniela waiting for him that didn't know that, I guess at that time, that there was Daniela there. And then they met at the Technical University in Munich, where Daniela is a radiologist and did a training in medicine. But interestingly, also did another degree in Master's Business Administration. But then as Franz got a little bit more attracted to the applied side of physics, then kind of like got together to work with Daniela, and I think really created a really wonderful and exciting scientific couple, and also private. So I guess we're very much looking forward to today's lecture. That'll be talking about X-ray dark field contrast for improved COVID-19 detection in chest X-rays. And I think particularly exciting is to go and wander from basic physics to first clinical results. So with that, I would like to again welcome you, Franz and Daniela. I don't know who's going to go first, but the floor is now yours.
Thank you. Thank you very much, Robert. It's kind of unusual opportunity, but of course we are very grateful for that honor. Being the first couple, and I think also the first Germans at the APS webinar here. So first I thought we thought it's a bit funny and maybe crazy, but now we're actually quite happy, because for me, certainly that helps me, because I don't have to go through all the medical details, where it's certainly not my expertise, and also for Daniela, she's happy not to go through these basic physics questions afterwards. So yeah, we'll let me just try to share the screen. So you just let me know if that works, right?
It works.
Yeah,
okay,
works.
Wonderful. Yeah, I'll hand over immediately to Daniela, because ladies first, obviously. I just wanted to have a few words in the beginning. We split. Daniela will start with the basic medical background on lung diseases and why X-ray imaging in general is actually a good idea for that. And then I'll walk you through the basic physics and some of the early development stages of this new modality that we developed now for the last 15 years. And we finally got it 2 patients last year. Yeah, and then in the end, Daniela will show you the first results for lung diseases. COPD, it's one very established disease where it's very important, but of course also COVID-19, where we have the first results now also available. Yeah, and with that, I hand over to Daniela. And
yeah, thank you. And so what we would like to talk to you today is a new imaging technology, namely Darkfield chest X-ray imaging. And I will provide you some background information about medical X-ray imaging in general. And I will guide you a little bit through the conventional and also these new Darkfield X-ray images. And a particularly important point in medicine in general is to make a diagnosis as early as possible, as the outcome is usually much better then, especially for the here listed top 5 killer diseases, as it is presented by the World Health Organization. So number 1 and 2 are cardiovascular diseases, ischemic heart disease and stroke, but already number 3, 4, and 5 are all related to lung diseases. So infectious diseases of the lung, chronic obstructive pulmonary disease, and lung cancer, as well as cancer related to the airways. And we will give you examples for all these 3 entities. And I will start now with the number 4, the chronic obstructive pulmonary disease. The abbreviation is COPD, and this describes a chronic inflammatory lung disease that includes 2 pathologies. One is a chronic bronchitis, which causes obstructed airflow from the lungs. And the second one is emphysema of the lung, and that means a destruction of the substructure of the lungs. So the smallest unit of the lung are the alveoli, so little bubbles. And here we have a direct air tissue contact so that we get the gas exchange and especially get the oxygen into the blood. So the bronchitis is shown here. So we have a narrowing of the bronchus itself, and the emphysema is shown here. So these are those little bubbles I told you. And I think this image shows it even better. So we have really, really small little bubbles. And these are all these alveoli, the smallest unit of the lung parenchyma. And in emphysema, we have this destruction. So there are really holes inside it. So we don't have the normal structure anymore. And the overall surface of the lung parenchyma shrinks significantly. So clinical symptoms in these patients include typically breathing difficulties and cough. And most of the patients suffering from COPD are smokers. As I said here, it's responsible for more than 130,000 deaths per year in the United States. But it's not all about the number of deaths, because this is a chronic disease. So there are a lot of people suffering over decades from this disease. And unfortunately, there's no specific therapy yet. And in the United States, 6% of the adults aged over 40 years are affected by COPD. So this is a really important disease and it really matters. Now I will show you how this disease presents in the medical imaging area. And I will always start with a CT. So in general, if we want to examine the lungs in the radiology department, we usually use X-ray imaging techniques. And this is why, this is because we have a really high resolution for radiography and also CT imaging. And we have a very high contrast between the air, which is shown in black, it's here inside, and the lung tissue or the vessels. This appears white here. So it's a really good contrast. And that makes it easy to depict if there are any pathological changes. So these are 6 different patients. And all the CT images are presented in a transverse slice orientation. That means like we go through the body like this. And now we see the different stages of emphysema. And we can have a closer look on the first patient. This patient has no emphysema. It's a normal CT scan. And I just want to show you how it usually looks like. So we see mainly the vessels and the bronchi. And the more we go to the periphery, the smaller the vessels are. What we don't see are the alveoli itself. So the resolution of a medical CT is not high enough, so we can't see it. We just see the lung itself and the air inside. So on the other side, this is a patient with advanced emphysema. So we have a destruction of the whole structure of the lung parenchyma, and there are really big holes inside. And I think now you can understand why these patients suffer from shortness of breath or have problem with breathing, because there are not enough interfaces between the air and the lung tissue anymore. And so we have an impaired oxygen exchange, and these patients have severe problems if they want to walk faster or do some sports or whatever. So this is the maximum severe form of COPD. But there are a lot of patients in between, mild or moderate forms of COPD. And there are some problems. So we see some minor changes here. There is a little bit of emphysema, but I think you will agree it's not so obvious. And nevertheless, we know that in these stages, we already have a significant destruction of the alveoli. However, they have a size around 50 to 100 micrometers, so we cannot visualize the alveoli directly. And so we miss a lot of diagnostic information. And we know that, but we can't do anything here. If we go to the X-ray imaging technique, then this is an example of a patient from our hospital with severe COPD and the typical signs of emphysema in X-ray imaging. And this is more or less no direct signs, but indirectly we can see that we have a flattened hemidiaphragm of both sides. And we have an increased diameter, anterior-posterior diameter of the chest. So this is a severe form of COPD. I won't show you mild or moderate. We simply don't see it in chest X-ray. So if we can diagnose it in an X-ray, it's more or less always a severe stage form. And the patient probably already knows because he has significant symptoms. So the next group of lung diseases we want to cover today is lung cancer. Lung cancer is probably a bit more known than COPD, and it is responsible for more than 150 deaths per year in the United States. And it also accounts for approximately 25% of all cancer deaths. So it really matters. And the US introduced a CT-based screening already, where they want to, or where they hope that they can find this tumor as early as possible, because of course, then the therapy is much better than in these advanced stages. So how does lung cancer in general look in CT? This is again a transversal slice of the chest, and we have the window setting again, or the lung window setting again. So air is black, and what we see here on the left side of the patient is a round mass. This is the lung cancer tumor, and it typically presents with these small spikes that represents the tumor spread into the lung tissue. And this is how we usually expect lung cancer looks like. And what I said before, it's in a lot of cases, we see the patients in already advanced stages. So in this case, of course, it's also easy to find the tumor also in an X-ray image. So we have the mass effect here on the right. And if we have a second look on the second view, lateral view image, then we see that we have a mass here in the on the right side in the lower lobe. This is easy to see. However, sometimes it's just a tiny lung nodule. I can show it to you. It's here. And then we want to see it also in the second view, because only with the second view we can be sure that it's really inside the lung, but it's not visible here. So in these cases, we need a CT, and then again, it's easy to see here. Same story here. This nodule can be missed in the X-ray image, but it is easily visible in the CT. So 2D X-ray imaging can help us in the clinical routine, of course. However, we are not happy with the performance, especially in terms of sensitivity. And this is especially for COPD, because I showed you we always see the very late stage patients, then we can diagnose it in the X-ray image. And it's also for lung cancer detection. It can help a lot if we see something, but if we don't see something, we are not sure that the patient is really healthy and there's no nodule inside. Yeah, and last year, a new lung disease came up, that's COVID. And probably everyone knows at least the basics today. It's a disease caused by severe acute respiratory syndrome coronavirus 2. And typical symptoms of COVID-19 are quite variable. Often it includes fever or cough and breathing difficulties, and typically also loss of smell and taste. So fortunately, most of the patients develop only mild or moderate symptoms. However, there are up to 5% with really critical symptoms like respiratory failure, shock, or multi-organ dysfunction. So these patients have to be in the hospital. And yeah, this is the point where we, during all these last time, we had a lot of patients suffering from COVID also in our hospital. There are some typical findings in CT, how COVID patients usually present. So we do a low-dose CT in these patients, and this is often included into the normal diagnostic workup of COVID. And the two typical findings, what we expect, are usually affecting both lungs, so the right side and the left side. And we have these ground glass opacities. So this describes how it looks like ground glass. And then we see typically these thickened interlobular septal. And if we have a look at the distribution of these lung changes, then it's typically more in the periphery and has some central sparing. This is an example from another publication in radiology. So again, they always say it usually starts with ground glass opacities, and in the later stages, then it's more consolidated. So we have this consolidation, but again, mainly located in the periphery. How does it look in chest X-ray? So these are different stages. So this is just a mild form of COVID here in this patient. I think this arrowhead really helps us to find the loss of transparency here. So this is probably ground glass opacity, which is responsible for this effect. In this patient, it's hard to say, though. There is we see there's less transparency on both sides. This is often not clear if you have just a chest X-ray. It could be that there's a superposition of a lot of soft tissue here, and so it depends on the habitus of the patient if this is, if you think that is normal or if it's sign of an infectious diseases like COVID-19. Here it's a bit easier, so we see the difference between the more healthy side here on the right and these pathological changes on the left. And I think this is quite easy then. Everyone will agree that this patient has a lot of changes in the lung parenchyma, and this is related to the consolidations within the lung parenchyma of a patient with severe presentation of COVID-19. So you've seen we use both X-ray and CT in our daily routine, but I've shown you that there are some major limitations of chest X-ray compared to CT. However, the main disadvantage of CT is that we have to expose the patient to radiation dose. And chest CT, even in low dose technique, typically comes with 2 to 4 millisieverts. And in comparison, the chest X-ray needs only 20 to 40 microsievert. That means a factor of 100 less than a single CT examination. So that's the reason why we don't only use CT for our examinations of the lung, but we take more than 100 chest X-rays at our department every day. However, in the clinics, we know that there are limitations of this 2D technique. So it would be highly appreciated if we could increase the sensitivity of this very important basic imaging modality. And this is where Darkfield imaging comes in. And now I will hand over to Franz, and he will present you the basic idea and how we brought it to the clinics.
So, thank you. So let me continue. I show you how we can now improve basic X-ray imaging by introducing a different technology. It's of course not a completely new physics, but it is essentially the exploitation of a well-known fact that has been around since at least 100 years. And that is the fact that X-rays can, of course, be as visible light, be interpreted as particles, but at the same time, of course, also as waves. And this wave interpretation is, believe it or not, in radiology, not at all used today. And this is the contrast that we try to exploit in Darkfield or in phase contrast imaging. Well, a few words about the basics. Well, we as physicists, we write, of course, X-rays as traveling waves with some kind of K vector and some kind of oscillatory frequency. And when we pass it into medium, we typically express that in a refractive index with some real part and an imaginary part. And the if you now sort of try to work out what happens, then you actually have K prime, the wave vector in medium is N times K, and this leads essentially to a phase shift of this wave and an attenuation. And this attenuation, this is what actually creates the normal well-known X-ray imaging. This is the attenuation contrast containing the photo effect and the Compton scattering. And the phase shift, this is what we are after. This is what we actually want to use when we talk about phase contrast or dark field imaging. So it's a well-known effect, but hasn't been exploited in radiography so far. Yeah, I mean, there are several attempts in the literature since many years. People are trying. I've been working or introducing a new one, actually working with gratings, and we use these gratings sort of to detect refraction. Refraction is one way that that the phase shift, or refraction is one of the causes that the phase shift in matter actually is leading to. So when you think about a wedge, the X-ray beam will actually make a little inclination angle and get refracted, and this effect is very small. It's only a few microdegree. This is why you usually don't see it in an ordinary X-ray radiograph, and we use these kind of gratings essentially as a multi-collimator slit with a reference grating setting up some certain periodicity pattern, intensity comp at a certain distance, and then an analyzer grating. You can easily imagine then if this is shifted, we get a change of the net transmission on the detector. This, in that way, we can use gratings to pick up the refraction. You can't just place these gratings anywhere. There's a Talbot near-field diffraction effect. This is the Fresnel diffraction regime. And depending on what periodicity and whether you have an absorption or a phase grating, you have to respect certain distances where the contrast is maximum. But if you do it right, you can also with ordinary X-ray tubes, and this is really the beauty of this approach because it's very efficient and also tolerates polychromaticity. You can actually do phase contrast or refraction like X-ray images where you could before only do attenuation-based X-ray images. And in that way, you get an additional contrast channel that eventually improves the sensitivity. Dark field imaging is also essentially a phase effect. It's pretty much the same as refraction, but it's a not coherent refraction effect where, like in a prism, everything goes in one direction. This can best be visualized in a way that you have a sample with many small inclusions, like for example, the alveoli in the lung. There you have refraction, multiple refraction in different directions. So you actually get a smearing of this nice intensity pattern, a sort of decoherence, as we also say. And if you pick that up, you basically pick up coherent small angle scattering, and this relates to the microstructure. So dark field in essence is the same as phase contrast. It's just not a directed effect. It's essentially a multiple refraction phenomena on the micron scale. The images that result out of that are kind of really complementary, showing the microstructure. So there's a pencil sharpener. In the attenuation image, you see, of course, the metal blade very strongly because of the photo effect and the Compton scattering. And in dark field, you now suddenly see mainly these microstructural changes of density in this scraped of wood pieces that generate a contrast. That's one of my favorite. That's a cup of cappuccino. Of course, the water absorbs, attenuates the X-ray beam to some degree, but the foam does not because it's pretty low in density. but it scatters a lot because it has many air tissue interfaces. And this is essentially why phase contrast or dark field imaging in that case is also so sensitive for the lung. Yeah, actually, with this method that we have, we can, and I'm not going to details, we can separate the attenuation by actually doing some kind of a Fourier processing of this intensity oscillation that we record on the detector by moving one grating across the beam path. We can extract the total transmission. This is the conventional image. We can extract quantitatively the refraction signal and the dark field signal, which is essentially the amplitude of the sine wave. And in that way, we can also separate these effects. Yeah, as I said, that was developed on the optical bench some time ago, about 14 years, about now 13 years, and has at that time led to quite a few publications and also to a very increased interest for medical applications, because I said that this method really tolerates polychromaticity and relatively incoherent, so medical X-ray tube sources quite well. We started with a lot of preclinical research many years ago, 6-7 years ago, and basically first translated this technology into a small animal scanner. And you can see on this screenshot that the actual raw data quality is pretty bad, but you can, via this processing that I just sketched before, calibrate or calculate or analyze, process out the attenuation, the dark field, and the scattering image. And in that way, you can, that was the first time for a living animal at that time, make such a threefold multi-contrast X-ray image, with two being based on the phase shift or the small angle, coherent small angle scattering for dark field, and the refraction for the phase contrast, and the normal attenuation image. And you already see that refraction actually might give you sort of increased sensitivity for some of the soft tissue structures, whereas dark field really highlights microstructured material in the body. And that, for example, goes in particular for the lungs, as you can see here. And that it's also for the hair here, but that's probably diagnostically not so relevant, but the lungs really stick out. Also the bones present a kind of strong signal. Yeah, we then basically studied a whole bunch of preclinical evaluation experiments in mice, starting with COPD, because also Daniela showed you that COPD is really on a larger scale a quite important disease, where early detection with low dose would be really interesting to have. And this is just some results from one of these many mice experiments. We did a control group in attenuation, a mice group with mice where COPD has been introduced 21 days before, and you can see almost no change in the attenuation in the standard X-ray image, but you see a consistently reduced intensity here in the COPD case, because the number of alveoli has been significantly reduced by this disease. So you get microstructural, almost functional information on the lung, and that with an ordinary X-ray radiograph, or basically just a pimped X-ray machine without too many additional technical modifications. Yeah, so this is also COPD. We can also stage. You can actually follow the severity of the disease. So it's we do understand this imaging channel. It's essentially related to the number density of alveoli that we are seeing in the dark field image, and this goes down as the disease progresses. Daniela talked also about lung cancer. We did a few mice experiments. You always have to do mouse before you move to humans. Nobody would ever let you build a machine for humans when you haven't established that in quite a few mouse models first, of course, to make yourself feel more comfortable. It did work in lung. This is a preliminary experiment with some kind of lung cancer induced, and you see, due to the fact that we are actually getting rid of the overlaying tissue and the bone, we can nicely pick up and see and identify these lesions. And in this preliminary experiment, we found something like a 244% improvement for lesion characterization, of course, to be followed up in patients soon. Yeah, and coming now slowly to experiments that also hint at why this might help for COVID-19. COVID-19 is some kind of pneumonia, and that basically means there is inflammation going on in the tissue of the lungs, so there's material added. And we found that by chance in one of these experiments where we introduced COPD, and this is the COPD mouse at day 21 after that has been introduced. And you see there that the tissue structure has been modified in the way as is expected for an emphysema. But right one day after we started with the experiments where you actually instill something in the lungs, we got an inflammatory, almost pneumonia-like reaction that looks like that in the histological slice, where actually material is added, but at the same time, the dark field signal tremendously went down. So we got a response in the dark field channel where almost nothing is to be seen in the attenuation channel. And this is now that was basically one of the motivations to also go for pneumonia or COVID-19. You can somehow understand that in that way, this is a really nice way to think about it. If you take a sponge, essentially, and you fill it with water and you look at that in the attenuation channel, this is the dry sponge, pretty much no attenuation or very little only because it's quite low in density. When you add water, the drenched sponge has a very strong attenuation or has significant attenuation. In dark field, it's kind of funny because it's actually the opposite way. So you add material, you add water to the sponge that has a pretty strong dark field signal initially, and then it actually goes down because you efficiently remove air tissue interfaces because you're adding water to the sponge. And this is also what happens in COVID-19. And this is why we were so motivated to also do that on the patient scale. Yeah, coming to talk about the clinical translation of that methodology that kept us busy the last 6-7 years after all the small animal experiments. First, we went from mice to pigs because it's not so much different from humans in many ways. Yeah, so that is what we call our pig scanner. It's a vertical setup with the X-ray tube at the top, a medical grade X-ray tube, and the detector below, some kind of table here. And that was a big effort, and it finally sort of paid off because we could see that we also get a significant imaging signal in the dark field channel for a lung that is almost the size of a human at high energies and a large field of view. Nobody has ever done a dark field image or phase contrast image at these energies. So this is 70, 80 keV and this field of view. So that was very important for us to be sure that it also works with some of the grading parameters that we thought about for the human scale. Yeah, a big effort and quite a big hurdle was grading fabrication. We are using microstructured grading actually made with LIGA X-ray lithography at the Karlsruhe Institute of Technology. And because we can't have a really big grading in one piece for now, we had to stitch that together. And this was also a tour de force by several PhD students that made the structures and then also aligned it. And this is one of the first interferograms that basically shows that, yes, it does work for these high energies and extended field of view. Yeah, based on that, we did then the final step, so to speak, or we did really attack the goal of translating that to the clinics. We built a system, started 2015 with the planning and basically started the project in 16. It's a horizontal system because you have to do most patients upright when you do chest X-ray exams. It's actually a sort of a hybrid scanning machine, again, because we don't have a large 43 by 43 centimeter grading available for now. So we only have something like 5 centimeters times 40 centimeter in width. So it's actually moved through the patients in 6-7 seconds breath hold, but in the end, it does work, as you will see in a second. Yeah, the construction was, it's probably a bit boring here, but it's I just want to mention that, I mean, this is really a home-built system, and for many years, I think nobody in Germany has built a clinical X-ray system for because all the authorities were also kind of surprised that a university sort of attacks that alone as a problem. Yeah, what we do is we move, and this is a shot of the raw data, we actually move this slot across the patient, as you can see here. And you also see all these fringes that are also moving along once again. Here we go. And there's a lot of jiggling and wiggling going around. So there's those vibrations that we have to remove. So we actually adapt the processing. We fit parameters for the actual vibrations and the movements to get all this sort of fitted. And in the end, we go away from the Fourier processing, go to some kind of a log likelihood fitting that also allows us to include mismatching tiles and these kind of things. But in the end, we do get a transmission image and a dark field image and also a phase contrast image that I won't be showing because it's in this case not so relevant. Yeah, we did a lot of commissioning in the initial phase using well-known phantoms as they are available and basically stuffing them with cotton wool as a replacement or mimicking the lung because there is no dark fields phantom for the lung, and that actually did quite well. We did a lot of those calibrations and tuning here so that we finally go down to something like a 45 microsievert for the total exposure for these two images, which is actually well within the guidelines and actually is about a factor of 100 below a chest CT scan. Yeah, and now my job is done for here, and I hand over for the clinical results to Daniela.
Yeah, so I think now we should have a look at the first images. This is probably the most important step now. Just here, one picture of the patient setup. So you've seen the whole thing before. We have a normal X-ray tube and a normal detector, but the whole machine looks a bit futuristic, and the whole arrangement is different to what we are used to, because it's the scanning system prototype. But now let's have a look at the first images. So this is a 33 years old healthy patient. So the lung at least is healthy. And this is the conventional chest X-ray as we are used to see it. And this is the additional dark field chest X-ray. So both images are derived from the dark field scanner system. So how does the lung look like? So we have a very bright signal here, more or less homogeneous. And this represents the scattering of the X-ray beam to the multiple air tissue interfaces in a healthy lung. So of course, we don't want to see just healthy patients. We have to see how does specific diseases change the signal. Do we see any differences? So on the left, it's again the same healthy patient. And now on the right, I added an patient who suffers from severe COPD. So there are indeed radiological signs of COPD here. No direct signs. I told you before, this is really hard to see, and the resolution doesn't help us here to get a deeper insight. But we can see some indirect signs like this flattening of the hemidiaphragm. This is the only hint we have. And yeah, this is what we can see in the X-ray image. Now let's add the dark field images. And I think if we see the corresponding dark field images of these two patients, you don't have to be a radiologist to realize that something must be wrong with the patient number 2 here on the left. So if we expect this high signal of the healthy lung, then we see here that we have an almost complete loss of dark field signal in both lungs. And the reason for this loss of dark field signal reflects the destruction of the alveoli, and therefore a decrease of the interfaces. And this is what we, physiological need. We need these interfaces to get the oxygen into the blood. And we also need the interfaces to get a dark field signal for our dark field imaging technique. Dark field diagnostic allows not only a black and white diagnosis. So white means high signal, healthy lung, and black is severe COPD. But it also allows for graduation of the disease. And you've seen that in the mice experiments, but it also works in patients. So here in the middle, we have a patient with mild COPD. And now you see the normal chest X-ray looks more or less exactly the same like a normal lung. There are no changes. There are no hints that something is wrong in this patient. But if we have a look at the dark field image here, then we can see it's not as dark as the severe COPD patient, but still we see a loss of signal here. And it's not the same appearance like a healthy lung. So this is very important because these are the patients where we want to make our diagnosis, not at the very end stage of the disease, but here at the beginning. And up to now, we have more or less no possibility to do this in an image procedure. So we have a huge study running on COPD, and in total, we want to include 500 patients, and we have already scanned 96 patients now. And this figure just should give you an overview about the detailed graduation that we can derive in dark field imaging. So it starts with a healthy lung and really bright signal, and it goes down a little bit to the mild forms, moderate forms, where it's more gray. And then here are several patients with severe COPD where we have, partly completely loss of signal, or at least a really dark signal and no bright appearance anymore. And just for comparison, if we have a look at the chest X-ray images, yes, sometimes we see this flattening, but even in this patient who has no severe COPD, he's just, based off his constitution, it looks quite similar like this severe COPD patient. So it's quite difficult to make the diagnosis of a COPD only based on the chest X-ray, but if we have the dark field information on top, it's much easier now. So this is just the condensed clinical results of the COPD study. And here we have a 58-year-old patient. He was a smoker, and the X-ray image looks more or less normal. However, here we see severely reduced dark field signal in the upper lobes on both sides. And now we collected a variety of data which describes the lung function. There are a lot of parameters. I just want to show that I don't want to show it in detail. I just want to highlight this image where, for illustration, we have an overlay of the results of the CT emphysema index, which can be calculated based on a software tool of the CT scanner. And it correlates quite nicely with the results from our dark field image. So we have the loss of signal in the upper lobes, and the same says the emphysema index, that we have severe emphysema in the upper lobes. So this is, again, a slide which contains a lot of information. I just want to highlight one aspect. So on the left, you see the box plots that present the standard measurements of COPD. This is a questionnaire, the CT emphysema index, and the lung function test. And for all of them, we have more or less no changes in the mild, moderate, and only trace varieties of COPD. But then in the late stage, severe COPD, all of these tests realize, okay, there's something wrong. If you compare it to the dark field, we have a significant change already in the mild stage, and on the moderate stage, it's quite obvious. And of course, we can see it in the severe stage as well. So we can get a more deeper insight into the severity of COPD. And also, if we have a look at the homogeneity of the dark field signal or the texture itself, we can get detailed information that we have not yet available, even if we use the functional lung tests. So while we were doing the COPD study, all of a sudden COVID came up last year. And of course, we were very curious to see how this new lung disease would be presented in the dark field image. And we had to change the setup a little bit to ensure that the study physician is not in danger of becoming infected. And we imaged a total of 60 patients now. And these are 2 X-ray images of men. One is healthy, one has COVID-19. And I think you will agree that there are no obvious signs of COVID visible here. But if we add the dark field images, we see the typical presentation of a healthy patient with a high signal on the left. And we have a significantly reduced dark field signal in both lungs of this COVID-19 patient which was in our hospital. Same story here. One is healthy, one suffers from COVID and needed medical care at our hospital. And again, it's hard to make the diagnosis just based on the X-ray image. But we have a significantly decreased dark field signal here in this COVID patient again. And if we put all of them together, then we see the two examples of healthy patients with a bright signal in both lungs homogeneously. And we see the generally reduced dark field signal in COVID patients. So beside this effect of a general signal loss in COVID, we found also more focal changes in dark field signal. And this is a patient who presented with a patchy ground glass opacities and consolidations in the CT. And in the corresponding dark field image, we also see in the periphery, there are a lot of dark spots here. And usually we would expect here a straight line of the chest wall. And in this patient, we have these spots which correlated nicely, also visible here in the chest X-ray. And here another patient, again, we had this patchy ground glass and focal consolidations here, especially in the upper lobes of both lungs. And we also have a CT available for this patient. Okay. So we see here that we have the ground glass opacities in both upper lobes, and there are also more consolidated areas, especially here in the left upper lobe. But also here we see several ground glass opacities. And this is what correlates quite nicely to this dark field image. We have these patchy areas of significantly decreased dark field signal, and we have a general loss of all other parts of the lung as well. So this is a combination of both observations we made in COVID patients. So if we conclude this, we have obviously two different classes. The majority of patients have a generally reduced dark field signal, and we don't see a correlate or a correlative finding in the conventional X-ray. And in addition, we have these patchy ground glass opacities in the periphery. And we can see this quite nicely in the dark field image, as these areas are often masked in overlaying ribs in the conventional chest X-ray. So this gives us an important additional information. So it's easier for us to detect COVID if we have both images available and can make our diagnosis with both of the images together. And with that, I now return to Franz for a short conclusion and outlook.
Hello again. Yeah, so it's my honor to wrap that up a little bit. I hope you got a bit of an insight into how far we are with this kind of study, both for established lung diseases and COVID now. Yeah, 15 years from bench to bedside. I think that's kind of right. Take-home messages for today, as X-ray dark field radiography is concerned. I hope you are convinced, or we managed to convince you that it's a technology that adds to conventional X-ray imaging by adding microstructural information and changes. I mean, we showed it to you in the lung, but think about the cappuccino, and a good example will also come at the end. So this is really something new that you don't have access to, or to this length scale for now with any other imaging modality. Yeah. It can successfully be translated to patients. What we've shown is actually the worldwide first patient application ever. And I hope many will pick up on that. And of course, also translation to broad applications is something we really envision. Yeah, we've shown you examples of COPD and COVID-19. COPD because we started with that before COVID came around, and COVID because we had to switch because we couldn't do anything else. And I guess in both cases, it's really evident that it helps the early detection in normal X-ray radiography. Yeah, and finally, we should just again mention that this is really an entry exam. It has 100 times lower dose than CT, than low dose CT, which is often advertised for screening. But of course, you have to be a bit careful with that. A normal X-ray imaging or dark field X-ray imaging would be much better as a screening modality before you escalate, of course, to then CT or something else. Yeah. What's next on our roadmap? Publish first results. If you want to know more about the COPD results, there's a preprint available. I hope the paper comes out next week, or the paper is accepted next week and comes out a little later. We are about to write up and publish, of course, the COVID-19 results, and we have just applied for a new cohort to look into more patients. And what is really driving here is, of course, that we have to see if we can eventually discriminate that from other lung diseases, in particular other inflammatory diseases, because that would be really good then. If you take the attenuation and the dark field signal together, that would be kind of interesting. Then, of course, lung cancer is on our roadmap. I would be super interested to look at tuberculosis. We don't have many cases in Munich these days, but in other countries it's certainly still an issue. So that's something to look in. And lung fibrosis also as a side effect of radiation therapy. Yeah, finally, next step after radiography, CT. we are working also on CT. It's a different story in terms of complexity. I mean, if you spin around these gratings at 20G, you can imagine that not everything will go according to plan. But we are making progress. I hope that also in half a year or so we have first results, at least from human scale phantoms, and then humans eventually next year, hopefully. Yeah, and with that, of course, this involves many people from my group and also from the clinics, working closely with Philips on some of the aspects here. I mentioned the Karlsruhe Institute of Technology, that is very important for making these gratings here. Big team from my group and from Daniela's group at the hospital. There are several doctors involved, yeah, with that, we thank you for your attention. We can't see you, unfortunately, but we hope you are sitting there with smiling faces and not like, oh, whoa. So yeah, and of course we're ready for questions, and yeah, thank you for your attention, I guess. So this is what we're having in a second after so it's a German Weissbier.
Great.
Yeah. Good.
This is really great, Daniela and Franz, and really appreciating, I think, getting us through the journey, in this 15 years from this really fantastic fish images to now COVID patients. I'm sure that 15 years ago he had no idea that this is what you'll be using, this technology. So I would like everyone to obviously to put questions into Q&A. We got already a couple, so we'll just go through that. So please use Q&A, not the chat part. And then I'll maybe just start with some of the questions that came. And I think very, very relevant, starting with COVID. And the question is the change in the lungs from COVID-19 permanent, or does it get back to normal when the patient gets better? Have tests been done on such patients? I'll just add a little bit to this, that I think, from the acute phase of COVID, obviously the COVID survivals will be really the major burden on the society and is a significant issue. So how do you see, in general, imaging to be related to this? So not just like Darkfield, and then, more specifically to the Darkfield, the importance of imaging in the following up COVID survivors.
Yeah, so what we see in CT is that, of course, the majority of these changes that I've showed you in the COVID patients, this is reversible. So this majority goes back, but what we've seen in some patients that there are still some, it looks like scars. So we don't know if it's really a scar, because there are no histopathological findings available at our hospital, at least. And I think there are no studies on these details, because we need some more time to learn what stays in the lung. But so usually if a patient recovers, feels good, and goes out of the hospital, we won't do an additional CT at the end just to see if there are still any changes. So perhaps we can do a chest X-ray to see if it looks normal again. But these tiny changes like scars, or yeah, it's mainly looks like a scar as we know it from other diseases. This wouldn't be visible in a chest X-ray. So we would need a CT. And of course, because of the radiation dose concerns, we won't do it if the patient feels good. But there are cases in the literature that patient came back and even 3 or 4 months later, and they say that they don't feel like normal again. If they do sports or whatever, they they have problems with breathing, and they did a CT in some of these patients. I've seen a study there, and yeah, these patients still presented with lung changes, which, as I said, look like scars. So obviously there is the possibility that something stays in the lungs, or that it's not completely recovered again. But I would say the majority of patients, yeah, more or less is, also leaves our hospital without any problems.
Yeah, just to add to this a little bit, it's about the estimates about 30% of patients' COVID survivals will have long-term effects or consequences. About 80% of those in ICUs or on ventilators. So 30% of those in ICUs and 80% those on ventilators are expected to have, or our first studies that show. So it is a significant problem.
Therapy.
That will definitely help.
I mean, if you could use this method for therapy follow-up, that of course would be kind of really interesting, because save a lot of dose. I mean, when you do when you have some radiation therapy for lung cancer, you do not necessarily always get a CT in intervals, but you start with X-rays, right?
Mm. Yeah.
So, and this brings me to a question, is, how quantitative is Darkfield imaging? Because if you want to do any, related comparisons, longitudinal, then obviously the quantitative accuracy becomes more important, because mostly you've seen, we showed more qualitative aspects, but I'm sure you've been studying the quantitative aspects as well. So can you comment on that?
Yes, I guess that's for me.
Yep.
I don't have a slide here, but actually the method is quantitative. So what we are actually measuring in the Darkfield signal is the number density of interfaces, more or less roughly. Of course, there's calibration parameters for the sensitivity of the setup and the wavelength and so on. But in essence, what we also did here is, for example, in this histology workup, we calculated the mean chord length. That's the average distance between the alveoli, and this actually corresponds directly to this projected alveolar density, or the projected Darkfield signal. You can actually model that when you do wave propagation through porous media. The problem is then you need to know your structure down to a few hundred nanometers, which is not always the case for a lung. But for other materials, foams or something like that, we can do that. And interestingly, the depth dependence follows also a Beer-Lambert law. It's an exponential. Essentially, you can think about like Brownian motion when you have diffusion. That goes also with the square root of the number of layers, and this is in essence becomes also a Lambert-Beer law with what we call an angular diffusion parameter. So I think we can also do CT, and that of course would only work when we can correctly quantitatively interpret it.
Sure.
Of course, there are a few second order effects that we do not yet understand, but in first approximation, it's understandable.
So if you said that, if you did a repeatability study, I don't know if you did, doing scanning same patient multiple days or multiple times, do you have an estimate of what would be the uncertainty in the numbers? So image intensity, not just like the relation to the underlying structure, but just like in the image itself. Any idea?
So actually, sorry, no. but what we do is actually we have to do by law. We do calibration phantoms and constancy phantoms. So every day when we start up the machine, we have developed a little cross 2D step wedge phantom. So we have neoprene rubber with increasing thickness that mimics the porosity, and we have normal absorber thickness. And these combinations are measured every day to make sure that the machine is always correct. And there's actually not much to do. This has been constant now for almost a year, pretty much. Yeah. Of course, when we change the algorithmic processing, it changes a bit, but patient-wise, Actually, I don't even know if we had patients.
No.
Okay.
No. Yeah, that's because we asked the authority, and we have the allowance to scan every patient once. This is because of the radiation protection thing. But of course, if we do the same, even if we do a normal X-ray 2 times a day, that can happen because it's before or after procedure, and it mainly depends about the breathing situation. If he inhales and stops breathing and you do the same thing again, that's very good comparable. But if the patient, for example, we take the image in exhalation, then it looks completely different. So this is, I think, much more important than between different days. It's between the different breathing situation where the patient stops.
Okay, so we got a couple of more clinical and then a number of very technical as well. So let's maybe talk about the clinical part. So one was whether did you show the general decrease in a dark field signal addition to the patchy glass ground glass opacity. So does that mean that there is a general change in light that conventional imaging is not picking up? So in other words, going from quantitative to just additional information that's provided by the dark imaging.
So this is a really good question, and I can't really answer it because we didn't expect to see a general loss of dark field signal. So what we expected was that we see the same patchy areas with reduced dark field signal comparable to what we see in the chest X-ray or in the CT, and this is what we just. So the first 60 patients, I don't remember how many there, but I think more than half of the number of patients had this general loss of dark field signal. And this is something new. We never described that in CT. No, there's no correlation to X-ray. Yeah, I think we have to investigate that further. I can't give you an answer yet what that means.
Yeah,
but it's quite convincing that there's something ongoing in the whole lung, obviously, and not only on these areas that we see in CT.
Yeah, and I think that's the there are two things. One is sensitivity, but I think that's like the additional information is that's really attractive. That I think really makes this apart. In addition to that, so that was part. So whatever was related was what's the sensitivity if you compare the dark field to CT, and I think you already implicitly answered to that. It's it's almost not comparing apples to apples, isn't it? But maybe you want to comment a little bit more.
If we compare the sensitivity of dark field X-ray imaging and
dark
CT.
field X-ray to the COVID PNA detection on CT.
Yeah. So this is the second study what we plan right now. So the first was the pilot study. We just wanted to see, can we detect anything or not? So this is the first 60 patients. And now what we want to do is, can we see a correlation between mild, moderate, severe COPD stages, COVID stages, and then we can learn or we can calculate kind of a sensitivity. And right now, at least we have seen, whenever we have seen something in CT, we also found some changes in the dark field image. But that doesn't say that that doesn't give us a number of sensitivity. So I think we have to wait until this second study that we can really say this in numbers. But we have the feeling that we more or less always see something. There's one thing. I've just showed you the images in posterior anterior direction. So it could be that the changes are more located behind the heart, for example, and then you won't see it here. So in this case, we would need a second view at least, then we can cover that somehow. But there are areas which are more problematic if you have just a 2D image. So I guess that we can't reach exactly the same sensitivity in terms of these patchy areas compared to CT, because a 2D method can't be as detailed as a 3D method. That's just a matter of fact. But if we take into account the general reduction of dark field signal, this is something new, and this could really help that we get the same or even better sensitivity than a CT on the micro scale, that we really have changes inside the alveoli, and not only these consolidations, the huge areas which are affected in the lung. But I think then we need really a correlation to the pathology and see if there are some minor changes in the substructure of the lung.
So there's another question in here, which is interesting, which is, do different diseases produce different patterns? For example, if you have patients who are asymptomatic with COVID, who later on develop symptoms, could you tell that they were because they had COVID, or is it some, could you distinguish that from COPD?
Very interesting question. The thing is that right now the procedure that how we include the patient is that we include only patients who already have the diagnosis. So we don't want to scan all the patients and then select the COVID ones. So of course we don't have any patients who where the COVID is detected later, but it would be interesting, of course.
Right. And then you said that the dosage level is comparable to an X-ray, but you must be taking multiple images, right? So it must be more than an X-ray.
Multiple? No, it's only one image.
Just a single image.
It's
but
one
you
single
said there
image.
was a diffraction, but wasn't there a diffraction grading that you were moving across the patient?
Yeah. So yes, we are taking several images. Actually, I showed this little movie here. Doesn't want to play anymore. All right, it does. So basically it's more than almost 100 shots, but we fractionate the dose such that the dose values that I've given for here, this is the whole dose a single element or pixel has seen. So these images that we have shown really only take these effective 35 microsieverts. This is for a 75 kilogram reference person. We have some dose adjustment for bigger and smaller patients, obviously. But this is really fractionated, and this is what comes out. It is a bit higher than a very good digital X-ray machine, but it's a factor of about 2 or something like this. Yeah.
And one more question is that since you're looking at the scale of the alveoli, would you improve your imaging by changing the frequency slightly, or varying the frequency to see if you can see substructures that you would miss with just a single frequency?
What do you mean with frequency? The repetition rate of the shots that we are taking, or the frequency of the pattern of the grading?
Of the X-ray. Could you change the frequency of the X-ray slightly?
So the energy.
This, like let's say dual energy Darkfield CT.
Yeah. Okay.
Darkfield X-ray.
Of course, yeah, that is something you have to do. Yeah, we are doing that, but on the optical bench, or not in the clinical machine. There we have an integrating detector. Yes, so the sensitivity for the structural sizes of the microporosity is related to some kind of a correlation length. And this correlation length depends on the grading parameters and the X-ray energy. And yes, you can tune that if you had a perfectly nicely centered energy at a certain level and you match it to gradings, you can essentially look at certain structure sizes more than at others. So it's essentially a pair correlation function that you can probe with. And yes, when you do true energies, you can basically shift this and basically tell something a bit about. You could say if it's more small structures, if you had a mixture of spheres, small spheres, larger spheres, you could basically determine the ratio of those two. Whether that's clinically helpful or not, I'm not sure, because the size ranges of a lung, it's so fractal that it goes all over the places. So, but there might be something in of course, yeah. I mean, sure, the next iteration of the system would use a photon counting dual energy or multiple energy detector, but when we started that was not yet available, and so on and so forth. Yeah. If you have some few millions left, give it to us, we'll do it. No, of course, this is to be done. Sure, that's the next step. Yeah.
So that was a good answer. So if anybody's got any extra millions, we'll get to that too. So
yeah, you can pick a disease, yeah, fibrosis, lung cancer, whatever.
So a little bit more technical. So you, if I understand, you're operating at a 70 kbp. So is there like any need really to, or you feel that obviously that's something which is acceptable in a standard attenuated mode of X-rays, but what do you think is the optimal operating energy for Darkfield? Have you ever looked at that? Just
So actually, from a clinical point of view, this energy is not acceptable because the standard guideline for a lung disease chest X-ray is 125 or 120 kVp in here in German Europe. So actually, we are operating out of specs. The reason why we do that is, but we have approval for that. Okay, so the reason for doing that is that we have a very strong energy dependence of the dark field signal. So it's much stronger at lower energies, A, and B, also because the grating fabrication becomes really more and more challenging for the higher energies. So we have now about 200, 250 micron height structures with on some few micron period. And if we wanted to work at 120, we would have to double the height. And that is really difficult. So this is why we are picking this low energy. We have run on cadavers and on phantoms lots of studies, and it turns out that this lower energy in terms of dose to signal or CNR to dose is better for us. It's probably not ideal for the standard chest X-ray, which would benefit from a slightly higher energy, but for Darkfield it is. One last comment on that, sorry. The guideline for this 120, you have to keep in mind that this was made 20 or 30 or 40 years ago when the digital detectors only came up, or when the digital detectors didn't have the good dynamic range. Now with additional post-processing, there's no reason to work at this energy. And actually there are lots of papers also coming out by really well-known radiologists saying that, oh, actually I would be better off working at 90 or 100. It might not be 70, but it's certainly lower than the 125.
Yeah, and my question was actually just, and pretty much, I mean, you answered it, that probably the optimum in general for the attenuation-based versus Darkfield would be not the same energy. And the question was, is the 70 optimal, or was it compromise? As you said, it's a little bit of both.
It's the optimal compromise for what we have. But if we had ideal gratings, I would expect it to be at 80 or 90 or something.
80 and 90 would be optimal.
It's just
so,
like,
Yeah, there is a couple of more just technical. One was, are your gratings straight or divergent angled? And then in general, what modifications you had to make to machine? What are the major the juice that you have to do to go to Darkfield in addition to?
So this is a divergent angle, obviously. So it's about a 2.50 meter distance from the X-ray source to the detector. It's actually not a normal X-ray radiography source, but more an angiography, a fluoroscopy source, because we need a bit more power because we're doing these many shots in a row. And yeah, it's divergent, obviously, in the plane. It's 40 centimeter field of view over these 2 meters. And the gratings are aligned such that they can easily tolerate that in that direction. We also have had to bend them in the other direction, because otherwise there would be shadowing in these grating structures. So the gratings are actually bent on a 2.50 meter radius here and a smaller radii here. Yeah, so it's a divergent setup in that sense. Yeah.
So,
your other modifications? No, actually, this is a commercially available X-ray detector, X-ray source, and a commercially available X-ray detector, like used in, as I said, in this case, Philips fluoroscopy systems. And we deliberately did that because we didn't want to have even more difficulties with the bureaucracy of getting that approved. If we would have, of course, we would have liked to pick a different detector, probably a new photon counting something, but that would simply in the initial go have complicated. I mean, we already took 1.5 years and about, 0.5 meter of paper to get that approved.
No, it's impressive. There was also one question just in terms of, but I think it's just a setup. Can you do the other views, so AP and lateral views, or so I guess it just depends on where the patient is. But you want to comment on this?
So the patient cabin is here. I don't have any large view, but yes, we have handlebars for AP and lateral view, and we have also for the COPD study we also have all lateral views. For the COVID, we didn't do the lateral ones now, but we will probably do later. We have a bit of a trouble with the bigger patients and the lateral view at the low energies that we are operating at. But for I would say 2/3, it looks quite okay. But we haven't actually gotten around to analyze them in detail yet.
So another question, and it's all day great. So there was a question: do you think the Darkfield can pick up a thrombus in the side blood vessel, and can you do the PE detection? But I'll just extrapolate a little bit. What would be the other applications beyond lung? There is obviously quite a bit of structure in the body that might be also heavy thought going beyond lung.
Yes, so I mean, in these last 15 years, we have looked at every part of the body. When I mean every part. So some do have dark field signal and pathological changes in dark field. We simply picked the lung, not because of COVID-19, because it wasn't around at that time, but because it appeared to us as the lowest hanging fruit, because this complementarity of the signal is so strong there. We did on excised samples a lot of work on bone structure, because osteoporosis, there the detailed trabecular structure, so not only the bone mass density, which is presently used as ±2 sigma range for osteoporosis, the detailed bone structure is very important. That's known from high resolution micro CT since many years, and that would give you an option to have access to the micron scale, so say something about the microstructure, microarchitecture of the bone, also when new bone grows, the callus and so on. So there we did a lot of previous work, and I think this would be, after the lung, one of the next interesting applications. Then another really hot topic is alternative contrast agents. We have lots of patients, Daniela could obviously comment more on that, is that have renal dysfunction. Is that correct, right? Yep. And so they can't tolerate iodine contrast agent. And we've done some preliminary experiments with microbubbles as alternative darkfield contrast agents. Microbubbles are totally harmless. They just disappear and that's it. Yeah. So if you in that way could do something about replacing iodine for certain cases, that would be interesting. Yeah, and then there are lots of mineral deposits in the body, in plaques, for example, in kidney stones, and these also have different microstructures. So, for example, we can relatively easily differentiate between uric acid and what is the other one?
Calcium.
Calcium kidney stones, based on their microstructure, because they grow in a different pattern. So these are applications. And then if you get a little more sensitive in dark field, for example, plaques, soft tissue plaques, they have different structure, fibrotic structure and more lipid inclusions and so on. There's a different dark field signal. Liver disease, fatty liver, liver cirrhosis seems to make a change in the dark field signal. And then quite a few works on brown fat we've done that differs from normal fat and also has a different dark field signal. So I think once you ramp up the sensitivity, more and more applications become, reachable from the clinical point of view. A lot of stuff has been done by several groups around the world on excised tissue samples that demonstrate the potential, I think.
Yeah, so and that's how Daniela and Franz took the world of radiology with Darkfield, isn't it?
Well, it's not that easy.
No, but I think it's been it's really exciting. I think just this opportunities and especially bringing this now to patients is just phenomenal. So I think we are nearing the end of Jan. Any other questions that you might have, or?
No, I just want to comment that it's very, very impressive what you have done. I hope it succeeds. I had one last question, that in some cancers, there's the way the blood vessels infiltrate the tumor is different depending on different stages and grades of the tumor. So could you, or even microstructures within the tumor, for example, in kidney cancer or in lung cancer, if you could see microstructures within the tumor, that would be able to help the pathologist make a better grade or stage for the tumor. Do you think that this is going to be feasible at some point in the future?
There would be probably a CT application. I think what is certainly feasible already now is a preclinical study based on the excised tissue to figure out if we at all get a signal change in Darkfield that would somehow reflect this changed microstructure due to the different entering of the blood vessels. How feasible it will be to crank up the sensitivity of a clinical setup operating at these high energies is hard to estimate now, because it really depends on whether this is becoming a big method or whether this is finding widespread applications, and then obviously also people making these gratings at better and better and more available quality. That's a key issue. It's like with photon counting. I mean, as the technology evolves, it sort of slowly trickles in, but it's probably worth a try. Do you have samples?
Very promising. No, I don't want to provide a sample. I don't want to be a sample. But
you want to be a sample? Sure. Come on over.
Okay. This is great. So thank you again, Daniela and Franz, for this really exciting talk, and obviously all the questions and answers. I think we should just now we got Katja also joined. So thanks, Katja, for suggesting. But also I would just like to say,
thanks, Katja.
A good wise beer. So Prost. And it's already getting dark. So thanks again. Here we go. This is a great way to end the webinar.
We think too.
Early for us over here, but like we'll think of you later today.
Of course. Thank you, Robert, for organizing.
Thank you.
And
everybody for watching.
Everyone else, welcome to John at the APS March meeting for more COVID-related stuff or everything else. So good night.
Good night.
Bye.
Bye.
Bye-bye.